Okay, so we're going to do a fluid and electrolyte lecture or review. So I basically want to give you a pretty good walk away with what's going on as far as fluids and electrolytes are concerned. I'd like you guys to walk away with the functions of what water does in the body and how important water is. And then I want to talk about the major electrolytes in the body and their function, and then identify common fluid and electrolyte imbalances, and briefly kind of cover how we treat those imbalances. So let's get started. In order to get an understanding of what's going on with fluid and electrolytes, you need to understand what the word homeostasis means. And homeostasis basically is that continuum steady motion, stability in the body, equilibrium, okay? So you want the body to constantly keep itself balanced, like on a seesaw. You want to keep itself balanced. So the body goes through many changes in the process of trying to do that. So when you think about homeostasis, I want you to think about steady, stability, and equilibrium. Water. One of the things I want you to know about water is pretty much how it's broke down in the body. Water is about 50 to 60% of the body's content, and a lot of things affect it. The sex of the person, their body mass, their age. Here I pretty much have stated that the water content in men greater than women, and of course there is the more obese a person is, the less amount of water that they're going to have. You need to understand that water is necessary for life. So a person can pretty much live for weeks without food, but they only can live a couple of days without water, okay? And I know somebody is over there thinking about, you know, I don't drink water. I've been living perfectly fine. But believe me, water is into food, and you can get some of your water out of food. So like I said, it breaks up about 60% of your body, and you lose a lot of... it decreases basically from birth to age, and most of that loss is going to happen within the first 10 years of life. As you're thinking about water, I want you to think about across the lifespan from your infant to your older adult. Infants have a larger body surface area, and so they end up having an increase or a greater insensible fluid loss. And when I say the word insensible, I basically mean that water loss that we really can't measure, okay? They have a larger body mass, so they have more, and that's going to make them more vulnerable or more at risk for fluid volume deficits, okay? Older people also have that same amount where they are having issues with maintaining their body water composition as well. And remember, as you get older, you have a decreased sense of thirst. You're not as thirsty as we are now. Also think about the size of a person. I mentioned up in there body mass. Think about the size. Muscle has more water, and fat actually has less. So I want you to keep all of this in mind. And as we go on with more and more slides, I want you to think about the body constantly fighting for that state of equilibrium, or homeostasis, as we will say, okay? So we're going to go on and talk a little bit more. Remember that water is also going to be the main transport of all the nutrients that the body needs. It carries our electrolytes, it carries our substance to all the cells, organs, and tissue, okay? Now we're going to talk about where is this fluid? What compartments does this fluid live in? And this is where students get all confused. So we have to really think about where this is. And I put this picture here hoping that you would have a better understanding of where that fluid volume is, okay? So we're going to talk about intracellular. Intracellular means that the fluid that is actually inside of the cell. So when you think about intracellular, I don't want you to think about blood cells. I want you to think about tissue cells, because that's what we're talking about. Intracellular as far as this is concerned. And then we have the extracellular compartments. And the extracellular compartments is also going to break down into anything outside of tissue cells, not blood cells, but tissue cells. So we're going to think about blood vessels, intravascular, interstitial, and transcellular. That's what we're talking about. And when you think of intravascular, as I'm pointing to here with my little highlighter on the screen, intravascular, this is where the phlebotomist is going to stick the needle to pull out any blood when we're getting blood draws to send down to lab for specimens. So I want you to remember that when I say intravascular, vascular meaning the vessel, that's where that blood is going to come from. And then when I think about interstitial, that is actually going to be in between the cells, okay, interstitial. And we always think about interstitial when we're thinking about swelling or edema. So think about that. The one that you're probably not so familiar with is going to be transcellular. Transcellular is that fluid that's in those special spaces. What do I mean by special spaces? The cerebral spinal fluid spaces, peritoneal spaces, pleural spaces, synovial fluid in between joints, that kind of spaces. So we have fluid in pretty much different compartments. But inside the cell, I want you to think about tissues, and I want you, in extracellular, I want you to think of outside the cell. And it's further broken down into 3 compartments: intravascular, interstitial, and transcellular. I also want you to think about your extracellular fluid accounts for about 40%, and that's going to be plasma. And your intracellular fluid accounts for about 60%, okay? So I want you to remember that. That is going to be very important when we start talking about what's major inside the cell, what's outside the cell, hypo this, hypo that. So I want you to remember those words. Obviously, we have to talk about electrolytes. Don't get all thrown off with the word. Electrolytes is going to be any substance who, when placed in water, actually breaks down into ions. So dissociate actually just means break down into smaller parts, and it becomes ions. Don't get all blown up about ions. Ions is going to be anything that when it's breaking down has an electrical charge, whether that electrical charge is a positive charge or a negative charge. So your cations are going to have positive charges, and your anions are going to have negative charges. Not that at any time you're going to get a test that's going to ask you about that, but it will help you as we go on with the next slide talking about the electrolytes, okay? Remember, electrolytes are only measured. They're not measured in milligrams or milliliters, but milliequivalent, or you'll hear nurses say MEQs, okay? So examples of some of the positive charge, the cations, are going to be your sodium, your potassium, your calcium, and magnesium. And then some of the anions, which are your negatively charged, is going to be your bicarb, chloride, and phosphate. And we're going to try really hard not to talk about phosphate. Anytime you hear somebody talking about plasma proteins, they usually carry a charge that is negative, okay?
Real quick.
Yes.
The positive charged ions are sodium, potassium, and what?
Oh, that's going to be on the next slide.
I'm sorry.
That is. No problem. There's no problem right there. So here are your electrolytes, okay? And I'm not really sure. This is our first time doing our presentation here, so I'm not sure if you can see them. So I'm actually going to try and see if I can make this a little bit bigger for you. So we have sodium here, and sodium has a positive charge. It is a cation. You'll see that as Na, and the normal range for sodium, and that's serum. And when I say serum, I am referring to blood, is 135 to 145, and that is milliequivalents, okay? Sodium, if you don't care about anything else on this list, I want you to pay attention to the first 2. Sodium is going to be all your neural stuff. It helps out with neurotransmitting of all of those electrical things that are going on to make your neurons, make your brain think, and make your muscles move. Potassium. Potassium is usually going to be represented by K, and it is also a cation. And the normal range for potassium is 3.5 to 5.1. And once again, those are milliequivalent. Potassium is very important. Sodium and potassium, they work with each other. One's in, one's out, one's out, one's in. That's the thing. So those are the 2 most important electrolytes. I guess that I shouldn't say that. Maybe those are my 2 favorite. No, but one's most important intracellular and one's most important extracellular. So keep those in mind. Calcium. Everybody knows about calcium. It's also a cation with a positive charge. And you will see some resources. Don't get so caught up in these numbers, but you will see some resources say that the normal range is 8 to 10, which is what I learned when I was in nursing school 11 years ago. And you will hear some say 9 to 11. When you are tested on this in a capacity of boards, they will make sure that if they want this to be abnormal value, it will be. Okay, magnesium is another one of those ones, and your potassium, calcium, and magnesium helps your myocardium, which is part of your heart muscle, which is your heart muscle, contract. So you want to pay attention to that one. It's 1.5 to 2.5. Chloride, 96 to 106, as I stutter because I learned 110. And phosphate, like I said, we're going to try desperately hard not to talk about phosphate. Phosphate is 2.4 to 4.1 milliequivalents. And this is basically when we measure electrolytes, we are measuring them in the extracellular, because remember, extracellular serum comes from the intravascular, meaning the phlebotomist came in and drew this out of the vascular vessel space, okay? Now, I would actually suggest that you put this in a flashcard or something, because you should be able to, when on demand, be able to tell potassium is 3.5 to 5.1, calcium is 8.5 to 10. You should be able to say these and know exactly what the normal range is. That should not be what your concern is. Okay, so just in case you are having any concerns or any questions about what we're talking about, all I've done right now is told you about how important water is. It's 60% of the body, and we need it so it can transport everything around where it needs to go. Men are going to have more water than women. Fat has less water. Little people have a greater risk of fluid volume deficit. There are compartments where this fluid is located. There are two major compartments, intracellular and extracellular. Extracellular further breaks down into three, which is going to be your intravascular, interstitial, and intracellular compartments. And then we had to talk about electrolytes. Electrolytes, remember, it's going to be anything when placed in water that are broken down into ions. We're not going to get bent out of shape. Ions have an electrical charge. It's either a positive charge or a negative charge. And then we talked about our electrolytes, okay? And they are very important, and so I want you to try to commit those to memory. Things that I think are very important, I will tell you that you should commit to memory. So, basically, I told you that I wanted you to think about, as your most important, is your sodium and your potassium. Remember, sodium is going to be represented always by Na, and it is a cation. And then your potassium is going to be represented by the capital K, which is also a cation. And I will say, where is sodium found in? Sodium is going to be most important or in abundance outside of the cell, and potassium is found primarily in abundance inside of the cell. So that's what this slide is representing here. Now, I know. Everybody's been really waiting on me to talk about fluid movement because everybody loves to talk about this. So let's get into it. So in order for everybody, all these nutrients and electrolytes to go where they need to do so that they can do their job, which is basically help out with, we got to have perfusion, we have to have nutrition and all of this. We have to have this fluid move, and it needs to move through what we call all these different compartments that I was telling you about. So in order for that to happen, we need to have what we call a permeable membrane. And when I say permeable, I mean a membrane which these particles can actually penetrate and go back and forth through. Okay, so in order for this to happen, we need to make sure that this can move. And basically how these fluids move is, the number one thing we're going to talk about is diffusion. So when you woke up this morning, the main thing you were focusing on is, I can't wait to find out what diffusion is all about. So here we are. We're talking about diffusion. Diffusion is going to be the movement of fluid from high concentration to low concentration. So how are you going to commit that to memory? I always try to think about when there's a lot of people at the party, I don't want to be there in case some stuff break off. I'm going to go to where there's less people so that I can get out of the room. I'm going to diffuse, okay? So remember, particles are always moving, and they're bouncing off each other, and they're knocking each other around, and they're dancing. It's like a big rave. Everybody's like, oh, and they're moving all around. So when they hit up against that semi-permeable membrane, they can actually move through that membrane, depending on how much energy they get from moving around, okay? So they're bouncing all around and they can go through the membrane, and they're going to go from an area of higher concentration to an area of lower concentration, because I can't dance and act the fool in this room because there's too many people, i.e. too many particles in this room. So I'm going to go to where there are not as many people. And a prime example of this is going to be just normal gas exchange. Osmosis is a little bit easier to kind of remember, because when you think about osmosis, we are only thinking about the movement of water. Okay, so don't get confused. Diffusion was kind of like as any fluid, and osmosis is just talking about water. But I do want you to know that osmosis is a type of diffusion, and this movement of water is going to be from a low concentration to a higher concentration. Okay, so basically what's going on is you're going to move from a hypotonic solution to a hypertonic environment until both sides are equal. And when I say equal, I am meaning both sides of this membrane I've been talking about, the cellular wall, the semi-permeable membrane, are equal or at equilibrium or in homeostasis. And when we think about that, we can think about the fact that when you pour your let's say when you pour Kool-Aid into your big water pitcher and it all disseminates and everything gets to where it's supposed to be, it's at equilibrium. There's not that one spot. Well, it could be at the bottom and then you got to stir it up, but you don't understand what I'm saying. So now we have your active transport. Active transport is an uphill movement. So in order for something to move uphill against the gradient, against what it is, it requires energy. And this energy that it requires is called adenosine triphosphate, and it actually helps with that. And the only example that you can really think about is the sodium and potassium pump. Remember I told you they move opposite of each other? That is going to be your example of that. I really hate to say this. At this level of nursing, you have to commit these to memory. For some strange reason, we want to ask you guys about this goofiness. But as we move on and we get to all the meat and potatoes, nobody cares about this as much. Now, I need to let you see what this semi-permeable membrane or this selectively permeable membrane. And when you think of selective, I'm going to let some things in. I'm not going to let some things there. So this is what it kind of looks like. And as you see things try to equal themselves out or reach this equilibrium, this homeostasis that we've been talking about. I thought it would be kind of cool to put that little picture in there. And plus, I like pictures. This is another slide that I wanted to throw in to let you know that basically that membrane, that selectively permeable membrane, controls the movement from one compartment to another. Obviously, things that are smaller are going to move through more freely, and things that are larger or less can move through there. So the big guy, they're a little nervous about letting him in the party. Smaller people can come in. Protein is one of those things. Protein is large, and when we think about when we get into renal stuff, which is the fun stuff, we can talk about how large those protein is and why we don't want it going through things. Okay. So this slide is going to be your representation of osmolality and osmolarity. And sometimes you'll hear us nurses use these terms interchangeable, but they're not really interchangeable. They actually mean two different things. So when you think about osmolality, you're actually thinking about the concentration of what a solution is when it is broken down or put into some kind of water or something. How thick, basically, is what it's saying, how thick something is. So the concentration is going to be per kilogram of water. Does that make sense?
Yes.
Okay, cool. And when something is thick and how thick it is going to control how freely things move. Kind of like what I was saying the slide before. Osmolality is actually used to describe fluids inside of the body, where osmolarity describes that fluids outside of the body. And like I said, you will hear people use them interchangeably. This is something that I actually want you to kind of commit to memory as well. I don't have it up on the slide, so I'm going to slow down just a little bit so that you'll be able to write this down. The normal osmolarity of plasma ranges about 270 to 2300. Big long range there. And like I said, this is when the fluid is how concentrated it is, okay? So here we go. Fluids that have a greater osmolarity of 300 are said to be hypertonic. If the osmolarity is greater than 300, it is said to be hypertonic. So now you're saying, what the heck is she talking about? You will see as we go on and we start talking about what happens with the fluids and where they shift according to how thick they are, how thin they are, okay? So think about that. If you have this greater osmotic pressure, meaning this greater concentration than normal serum, this fluid will tend to pull water from the isotonic spaces, okay? So if the osmolarity is greater than 300, it is said to be hypertonic. It tends to pull water from the vascular space into that hypertonic space. Okay, I just wanted to say it a couple of times so that you could kind of get what I was saying and you could take notes. Fluids that have an osmolarity of less than 270 are said to be hypotonic. And we use these words hypertonic and hypotonic to describe their osmolarity or their concentration in relation to the vascular space, the blood in the vascular space. Okay? And they tend to pull the water from the hypertonic space into the isotonic space. If the osmolarity is less than 270, they are said to be hypotonic. And then the last word I have down is isotonic, and isotonic is going to be that right in that balance, and that's what serum blood level is. Okay? Your next slide is going to be a better representation of hypotonic solutions, isotonic solutions, and hypertonic solutions. So up at the top here, we have actually blood vessels. And remember I was telling you blood cells. So remember I was telling you I didn't want you to necessarily think about cells as blood cells. I wanted you to think about them as tissue cells. So here's a blood cell, and if we put a hypotonic IV solution in there, it's going to pull the blood into the cell. That cell is going to swell. If we have the same osmolarity, the same concentration of the vascular space in an isotonic solution, it will not do anything to it. It is equal. As you can see, we have an arrow in and out. And then if we place the same blood vessel cell into a hypertonic solution, it actually shrinks. So as you get really, really motivated about what you're doing and you're learning this, and trust me, there are going to be questions that are going to that's going to require you to commit some of this to memory, and that is just what you're going to have to do. Here are your isotonic, hypotonic, and hypertonic solutions. And that is why we even brought this up, because in the nursing world, we give these solutions. Preoperative, postoperative, actually replacing fluid volume and all of this. So you might, once again, want to put these on a flashcard, print this out, put it in your back pocket, or whatever you need to do so that you can remember this, okay? So the first one I have up here is going to be your isotonic solutions. And your isotonic solutions are going to be your normal saline, your lactated ringers, and your D5W, which is dextrose and water. Okay? Your isotonic solutions are going to be what we use for fluid replacement. Okay? Whenever there is a fluid volume deficit in the extracellular space. Remember we said the extracellular space was that compartment where there's the vascular space, interstitial space, and transcellular space. So this is one of those things that you want to remember. Those are your three isotonic. And your isotonic solutions, as I slide over, they have the same osmolality as normal plasma. Remember when we think about plasma, we're just thinking about serum plasma, the blood. There is no osmotic pressure. There is no osmotic pull. Everybody is already at equilibrium. We are just replacing volume. Okay? So now we have this little side note in there just to confuse you, because isotonic is just the easy one to remember, that D5W is isotonic in the bag. So when we go into the Pyxis to pull out, or the supply room to pull out the D5W, it is isotonic, but as soon as we put it in the body, it becomes hypotonic. Okay? I know, it's kind of confusing. So, and just like that, I lost my thing. But we're going to figure it out in a minute, and we're going to talk about hypotonic solution. So your hypotonic solutions is going to be your, and we call this half normal saline. Okay, so 0.45 NS is sodium chloride is going to be your half normal saline, and it is going to be your hypotonic. How do you remember this? That's what you're saying. Shamel, how am I going to remember that it is hypotonic? It is less than 1. So that is how I want you to try to remember that it is a hypotonic solution. Also, your 1/4 normal saline is also a hypotonic solution. So your hypotonic solutions are going to usually be used when we have hypotonic fluid losses, and that's going to be usually when we need to add in electrolytes and that such. And we're going to talk a little bit more about when we're going to use hypotonic versus hypertonic solutions. Your hypertonic solutions are going to be your ones that are greater than or have sugar in. So there we'll have D5.5. We're going to have D5.25, 3% normal saline, 10% dextrose, and 50% dextrose, okay? I said I wanted you to remember the hypo as being less than 1, and that anything that was hypertonic would have either it's going to be a greater or it's going to have sugar in it. So think about your 5%, your 3%, and all that. 3% is obviously more than 1/4 and half. So think about that as well, because you're going to have to know these. There will probably be some goofy question in there to ask you about the different ones. So your, I don't know why I can't find my, why is that not working for me? Did I break it? What is that? Huh? Oh, thank you, honey. Mm-hmm. So, but it just won't let me do it though. Like really, I can't get out of it. Okay, cool. Homeostasis and the mechanisms. I'm going to slow down just a little bit because I know I've been talking fast, but I think that this slide is very important, and I didn't put a lot on this slide because I wanted to spend the time talking about how the body maintains itself in equilibrium, or our favorite words of saying homeostasis, okay? And although you may not realize it, those kidneys play a major role in fluid volume. That's their job. Okay? So, I want to let you know basically what goes on in the body so that you have a clear understanding of what's going on. The kidneys play a lot of games with getting rid of fluid, holding on to fluid, and its response to low sodium, low blood volume, and all of this. So the kidneys actually play the most important role in blood volume or volume. Okay, so they are very important as far as coming up with how fluid balance is maintained. The antidiuretic hormone, or ADH, is actually called the anti-pee hormone. So no peeing. So basically, this hormone is released in response to how concentrated your blood is. Okay? So obviously, if it feels that your blood is too thick and there's not enough fluid on board, it's going to tell your body, don't pee. So more antidiuretic hormone will be released so that it will hold on to fluid. It makes the renal tubules more permeable to water to reabsorb and return it back into the system. So when you think about antidiuretic hormone, I want you to think about no pee, anti-pee, I'm against pee. I want to hold on to my volume. The blood is too thick and I don't want thick blood. I want you to think about that, okay? There is also a synthetic form of that, and we call it vasopressin. We'll talk about that a little bit later, okay? The Renin-Angiotensin aldosterone system, okay? I have to be honest with you, I kind of like this system. Okay, so how the Renin-Angiotensin aldosterone system works is when there is a decrease in oxygenation, and remember, oxygenation is going to come from blood vessels, red blood vessels, actually perfusing the body, okay? So when there is a decrease in that, renin comes out to play. And what renin does is it activates this system, okay? The system basically has, renin comes out and it says, hey, how you doing? I'm going to start this angiotensin. Angiotensin 1 converts to angiotensin 2. Angiotensin 2 is a potent, what I mean by that is very strong, vasoconstrictor. So what happens is your partner got shot out on the corner. He's bleeding out on the street, okay? So basically now the kidneys are not getting the blood volume that they need. So it's like, hey, where's my volume? Where's my volume? So renin says, there's no volume. We're not having any oxygenation. Where is the blood? Hey, angiotensin, come on. Angiotensin 2. Vasoconstrictor, very point vasoconstrictor. So that makes the vessels smaller so we can get a better pressure. Anytime the vessels are constricted or smaller, we get a blood pressure, okay? So angiotensin 2, and then aldosterone. Aldosterone actually prevents water and sodium loss. So if we don't lose it, we keep it. Anytime we retain sodium and water, that's going to increase volume. And so we have more volume. Remember, angiotensin 2 made the vessels smaller. So now we have a better blood pressure. And then aldosterone actually decreases the sodium levels and makes you excrete potassium. Okay, that is the body's response to low blood volume, decreased perfusion, or hypoxia. Aldosterone makes you retain sodium and water and excrete potassium. Okay, and it's very important that you know that system. That system is very important. Then we have the atrial natropeptide, and this is the body's response to volume. And I love volume. As a matter of fact, I'm a cardiac nurse, and anytime I think about volume, I just get really excited because the heart actually controls a lot of that. So the ANP actually secretes in response to an increased blood volume. when you have increased blood volume and you have increased blood pressure, and that stretch in the heart muscles is going to make the body secrete this ANP. Okay. And it is very important. It actually has a opposite effect of aldosterone, okay? And remember I told you aldosterone is going to make you retain sodium and water and excrete potassium. So now you're saying, wow, what is going on here? Now, all you need is your thirst mechanisms intact, okay? So as long as your body can say, I am thirsty, you will drink, and that's another response to low volume, or and I'll say at the very minimum level, when your body says, hey, I'm thirsty, for some strange reason we go eat something, but basically you're thirsty. So it is very important. It's the body's first mechanism to keep you from being hyper osmolar, is to have your body says, give me some water. We don't respond to it well. And remember, we lose that as we get older. So some of you guys are up there, not me. So I have my thirst intact. So I'm hoping this kind of makes sense to you. We've talked about a lot of things in this 40 minutes. We've talked about compartments and how things shift through membranes and how things are really thick and how things are really thin, and the kidneys like volume, and things are telling us not to pee, and all of this different stuff. But it'll start to kind of make sense the more and more you go over it. And we will do some reviewing to make sure that we're getting a clear understanding of what's going on. Now, we cannot talk about volume and fluid if we don't talk about what happens in our geriatric patient. What actually goes on? What are those mechanisms that make the aging body change and how they handle volume? Okay, so there's structural changes in the kidneys because they've just been here for a lot of years that make the kidneys slower to respond to the volume changes. So remember on the previous slide, I told you that the kidneys are the most important thing. They handle the fluid volume. Well, the older you get, those nephrons, they can't handle all of this responding. So they're slower to adjust or slower to respond to that. You also decrease your sense of thirst, okay? The total amount of water in the body decreases as you get older. You have a loss of subcutaneous tissue as you get older, so an increased loss of moisture. So your frail elderly patient, especially if they're already sick, are going to be at increased risk of fluid volume deficit. Haha, I like that word. And so they're going to be more at risk for having issues with body. And then we're right now, if you take your hand and place your pinch your fingers and lift your skin on the top of your hand, the back of your hand, you can pull that up and it should just lay right back down for you. And that's how we check skin turgor, okay? And so basically what ends up happening is as you get older, your skin doesn't have the same elasticity. And what I meant by that is like pinch your skin up like this and it should fall right back down. Okay, so that's how we check skin turgor. And as you get older, the elasticity, and my skin turgor was fine for all of you that's wondering. As you get older, you lose that elasticity. So that is not a reliable way of checking. And that's another reason why on the screen we have check the sternum or the forehand for that. And then as you get older, your musculoskeletal system changes. You have arthritis, you have Parkinson's, you have different things that are making it harder for you to pick up your drink and drink. Another thing our elderly patients have a problem with is that they would prefer to not drink so they don't have to go to the bathroom because they can't get to the walker as fast, they don't move as quick. They're having episodes of incontinence. So sometimes for them, it's just easier if they just don't even, worry about going to the bathroom. So, like I said, I don't think you can pretty much talk about fluid and electrolytes without touching on the fact that there are age changes that affect fluid balance. So, of course, we're going to kind of slow down just a little bit and have a little quick review. So, diffusion, no energy is required. The only time we're going to have energy is when we are doing active transport, okay? It's not pressure dependent, meaning it doesn't matter what side of that membrane has more concentration or not. Osmosis doesn't require energy, and it only pertains to water. Osmosis does depend on osmotic pressure. And then isotonic cells remain in the same. They don't move or anything like that. It has the same concentration of plasma. Sorry. Hypotonic, the cells actually, the water moves inside of the cell and the cell actually swells. And for your hypertonic, water moves outside of the cell. And when it moves outside of the cell, those cells actually shrink. So that's a little bit, that's the part that I think people struggle with a little bit. That's why I tried to find the picture that would be absolutely perfect for you guys to kind of think about that. We're going to talk a little bit more about all the stuff that's important. I try to put really good handouts in here for you guys to use as you think about what's important with fluid and electrolytes. Now we got to talk about, as I am using all of my wonderful technology, okay, fluid volume deficit. So not to be all special and cute with the words, but fluid volume deficit is going to be a decreased amount of fluid volume in the vascular space. Remember, I said the vascular space is actually going to refer to vessels, okay? So fluid volume deficit, let's not get all crazy about it. That's dehydration, basically, in a nutshell. This is going to be your hypovolemic patient, your dehydrated patient. There is not enough volume in the vascular space to meet the metabolic demands of the body. So this is going to occur either with your patient that's not drinking enough or your patient that is losing volume for some other reason, an increase of sensible fluid loss. And remember when I said sensible, I said that's going to be what we can measure, and insensible is going to be the things that we can't measure. And there are different kinds of reasons that a person would have a decrease in volume. The patient could be hemorrhaging, they could be vomiting, they could have diarrhea, large amounts of drainage coming out of a nasty wound that they have. And then I wanted you to think about, and all of that stuff we can measure. Let's think about the patient who has a fever and they're sweating, they're diaphoretic. We can't necessarily measure that, but they also lose fluid. And let's think about that baby I was telling you about, that infant who has a fever. They already have the issues and being at risk for fluid volume deficit. Let's think about our burn patient, okay? If a patient has a massive burn and all of those vessels and skin, which is our #1 body's defense against outside organisms, if it's gone, fluid is shifting back and forth, they could be losing a lot of fluid. I also want you to think about a patient taking a diuretic, and I'm not 100% sure at this part of the game how familiar you are with diuretics, but that's going to be what the layperson calls a water pill, and it increases, makes you want to, makes you pee. So, or maybe I should be a real nurse and say something like, it makes you void. And so remember we talked about the antidiuretic hormone, and I said it was the anti-pee hormone. So diuretics, when our patient is swollen and we want to get extra fluid off of them, we could over-diurese them. The doctor could have ordered too much, or the patient could have gotten confused and taken too much. And so that patient is going to be at risk for fluid volume deficit. And we also have to think about the patient that is very sick and what we have third spacing. And third spacing means that the fluid is going to be accumulated in the third space, which is the interstitial space, the space in between the cells that we talked about in the extracellular compartment. So I just wanted to give you some examples of a patient that could possibly be suffering from fluid volume deficit or a decrease in fluid volume. Your dehydrated patient, your patient who is losing volume, loss of water, dehydrated, okay? Okay, and then this slide goes on and it talks about different causes of fluid volume deficit, and I hit a lot of GI tract, that's gastrointestinal tract, and that could be because we have the patient connected to suction, that could be the patient who is vomiting, the patient who has diarrhea that we talked about. We also could be having a patient that's going through some kind of issue with renal disease and could be going through a diuretic phase and they're diuresing a lot. And then anytime, like I talked about big burns and stuff like that, there is a loss in skin integrity, and that could also make you lose fluids. And there are some disease processes that follow as well, like diabetes insipidus, but we'll talk about that when we get to actually talking about disease process, which I'm much more excited about. Can't wait to do it. So we're going to talk a little bit more about how that patient presents. And when I say that, when I say clinical signs and symptoms, how does that patient look? What are they coming in complaining of? That's going to be the patient or the family member that comes in and says, my mom has lost 20 pounds in 2 months and whatever. Decreased skin turgor. That means that when I pulled my skin up on my arm, it went down slow. And you kind of saw what we call a little tint. It didn't just spring back in place. And oliguria means a decrease in urine output. And that decrease is going to be less than 400 cc's in 24 hours. Okay. So, of course, our patients is not going to say that, but I want you to know that our family members and patients are going to say, you know, I'm going to the bathroom like maybe once a day. And so that's one of the things. They're going to tell you that my tongue is sticking to the roof of my mouth. I have dry, sticky mucous membranes. My mouth is dry. My tongue seems thick. And that's the patient that's going to keep licking their lips because they are. So postural hypertension. So basically with that, you want to think about when this patient changes positions, they actually become hypotensive. Their blood pressure drops. And anytime that happens, you're going to get dizzy and weak and stuff like that. Anytime your blood pressure, which is hypertension, whenever your blood pressure drops, you're going to feel weak and your heart rate's going to speed up. That's your body's natural defense. Hey, where's my pressure? Where's the blood? What's going on? The heart is saying, I must be faster. I got to be faster because I don't know where the blood is. So that's your body's normal response to that. And once again, where's the oxygenation? Remember, the blood carries the oxygenation. So your respiratory center is going to compensate for the low pressure, for the low volume, and it's going to tell you to breathe faster. One of the things I want to do as I talk, because I'm making these videos especially for the Excelsior group, is that I want you guys to remember that infants and children don't have the same response to blood pressure changes as the adult, okay? And so I had to make sure that when I was preparing this lecture that I wanted to put things in that refer to the infant and the geriatric patient. So when they have a fluid volume deficit, they don't necessarily have those blood pressure changes, okay? Our older adult, they normally get confused. You know, their neural responses just don't work. They need that volume. So you could have your patient, Miss Johnson, who's at the nursing home, and she's really, funny and with it. And once she gets dehydrated or whatever, she becomes a little, what I call goofy. So she'll get confused, and she's probably not going to say things. The infant and the child, when they have a deficit in volume, they usually will have a poor capillary refill. And I'm not 100% sure if you are aware of what capillary refill, but I would like for you to basically press your thumbnail down on one of your fingernail beds and watch as it turns white. And when you remove it, it should pink right up. That's what we call checking capillary refills. So you're going to basically pinch the end of your finger and look at the end of your hand turn white and then turn pink again. Our little kids, they have slow or poor capillary refills when they're deficient on their volume. And sometimes they end up with mottled skin. So you definitely want to think about that. And then when you're checking skin turgor, remember we talked about that whole when I was lifting my skin up on the back of my forehead, and I told you it was better to check on the sternum or the forehead. It's a couple of slides back. For children, we're going to check that on their belly or their inner thigh. So for our children and infant, we're going to check skin turgor, meaning we're going to pinch their skin up to see how fast it falls back down. And we're checking to see how hydrated this patient is on their abdomen or their inner thigh. The best place for our older adult or our geriatric patient is going to be their sternum. Okay, so I wanted to make sure that I put that in so that we didn't have any issues with how to check that. Our next slide talks about laboratory findings, okay? Still talking about a decrease in volume. Still talking about the patient that's dehydrated, low on volume. And as you can see, I've actually bolded all for you. So in the lab, the phlebotomist comes in and they draw lab from the intravascular space, which is located in the extracellular compartment, okay? This patient is going to have a urine-specific gravity and a urine osmolality that is increased. So what I mean by that is, because the body is low on fluid, when the body is going to say, remember, antidiuretic hormone is going to be, hold on to my fluid, anti-pee, don't pee, hold on to my fluid, okay? I want to have that as much as possible. So when you do decide to urinate, it's going to be concentrated. It's going to be dark. So you know how it is. You go to the bathroom, you look at your urine, you're like, oh, I need to drink more water, or I can, see that. That's really dark. It almost looks like tea instead of lemonade. So that means you don't have enough volume on board. So that's how your urine is going to be. And just in case you want to put a side note, urine-specific gravity is 1.010 to 1.030. Okay, and then you're going to have an increase in BUN, which is blood urea nitrogen, and it is going to be greater than 25. Okay, so that's going to also be concentrated. You're going to have an increase in hemoglobin and hematocrit, and remember, you'll hear us call that H&H, and that is going to be because there's not enough volume on board. It doesn't mean you're overloaded with red blood cells. It just means in relation to the amount of fluid that is circulating in your body, there is not enough fluid for that. So it makes it seem as if your hemoglobin and hematocrit are increased. And we call that hemo-concentrated. Yes, sir.
Could you go over the urine specific gravity again? 1.10 to 1.30?
1.010 to 1.030.
Got it.
And you'll see some references, so I want to put this out here that will say 1.020. And don't get so caught up on the numbers. Know that if you have a urine-specific gravity that is 1.078, that your urine is concentrated. The lower the number, the less concentrated it is. And I don't want to put too much out there in the atmosphere, so I won't give you the other ones. So you're going to have increased electrolyte levels from hemo-concentration. So I want to give you an example so that you understand exactly what hemo-concentration is. All of us drink Kool-Aid, or all of us drink vodka and cranberry. And so let's stick with Kool-Aid so that I can keep this very PG. So you have your Crystal Light package, and you're going to put it in a 20-ounce bottle of water. And you got it. It looks really good, and it's, strawberry, kiwi, and it's red, and it's tasty, and everything is really good. And you like that. You like, I got my Crystal Light, now I'm drinking water, and she said that I had to be hydrated. But if you take that same Crystal Light package and you put it in a 2 liter of water, it's kind of diluted and it looks kind of pink. And you're like, I don't really know, And it doesn't mean that there is a different amount of Crystal Light that is in the 2 liter of water. There's the same amount that you put in the 20 ounce. It's just that there's more water on board. So there's not a decrease of hemoglobin or an increase in hemoglobin. It's just all in relation to how much water is on board. Okay, so I hope that makes sense to you, exactly what's going on. Also, try not to forget that when a patient comes in and they are fluid volume deficit, they are dehydrated, this patient is definitely going to be tachycardic or have an increased heart rate with the body's response to not having enough volume on board. So therapeutic management, what are we going to do? How are we going to treat this patient? What are we going to do to make this patient better? I want you to think about nursing. What do we do for nursing? Well, the goal right now is to replace the fluid and electrolytes and try to figure out what the cause is and what can we do for this cause. So if our patient can drink, we can drink. Depending on how dehydrated they are, we might have to give them IV fluids. But as a nurse, my job is to manage monitor the vital signs, the input and output, the electrolyte, the mental status, daily weights, and accurate urine output. And what you'll hear people say is strict I's and O's. Okay, so you want to make sure that you look at that. One of the things I want you to put in there, fluid volume and how hydrated a patient is. We like to look at how much urine output they have, and we will say that we need to have at least 30 cc's or milliliters. They are the same thing. And let me switch over to milliliters. I was taught cc's in school, but 30 milliliters per hour. Your patient or you should be voiding at least 30 milliliters of urine per hour. But I don't want you to get excited about 30 cc's. That is the minimum. That's a C. That is not an A on the passing scale. That's a C. That is the minimum that they can have. You also want to look at things like changes in their blood pressure. You want to see if their jugular veins are distended or are they flat. And jugular veins are going to be those veins that pop out and the person is pissed off in their neck. Those are the veins I am referring to. You're going to always want to make sure you are looking at them. And I want you to note that an increase of 1 kilogram is going to be equivalent to 2.2 pounds and 1 liter of fluid. Okay, so make sure that you are keeping in touch with your weight changes and all of that. And remember, I told you when there is a regular volume deficit, when we are replacing volume, we replace it with the isotonic solution. And remember, our isotonic solution is going to be our 0.9 normal saline and lactated ringers. We do not normally replace with D5W, okay? Unless the patient is NPO, have some kind of issue or something like that where we need to put sugar on board. But 9 times out of 10, we are going to replace with normal saline or lactated ringers.
Isotonic.
Yes, for regular volume replacement. So, obviously can't talk about volume without talking about volume excess. So, volume excess means that the body has decided to retain fluid, okay? So, in the vascular space, there is a lot of fluid. And this is going to be either from your patient who has decided they want to drink a lot of water, or bad nurse Nancy has ran too much fluids, or whatever the situation is, or the pumper. The pumper, meaning the heart, couldn't handle the fluid and put it where it was supposed to go. And so we'll call this water intoxication, where the body holds on to water and sodium levels decrease, and that's because it's diluted, okay? So this patient that is holding on to fluid is going to be your probably is going to be your patient either is going to have heart disease or renal failure. Like I said, the doctor put in an order for normal saline to run at 50 cc's an hour, and they decided milliliters an hour, and they decided to put it at 150 cc's an hour. Or the body has decided to secrete a lot of aldosterone. Now, remember I told you when the body's normal mechanisms to handling homeostasis, that the renin-angiotensin aldosterone system jumps out. Remember, aldosterone holds on to sodium and water, and it excretes potassium. So maybe something could happen where you excreting more aldosterone. That would be another reason why you could be in fluid volume excess or fluid volume overload. So these are some of the things that I want you to think about when you're thinking about overload and what's going on with the patient. Some of the causes, pretty much what I said: heart failure, renal failure, liver failure, lots of table salt, overhydration, poorly controlled IV therapy. That was Bad Nurse Nancy. Sometimes she's Bad Nurse Betty, but I wanted her to be Nancy today. Okay, so how does this patient look? What does this patient come to the hospital looking like? This patient is going to have what we call peripheral. Peripheral means the outer limbs on the outside. So that's going to be your legs and your arms. And pitting edema means that you can stick your finger down on their leg. Everybody has an uncle or aunt that has some pitting edema. Put your finger down on their leg and actually leave your fingerprint in their leg, okay? That's what we call pitting edema. They're going to have an increased pulse and an increased blood pressure. The reason why is because now we have all of this volume in your blood vessel. And it's going to make, the vessel is the same size. So that didn't change. You're just going to have more pressure, more volume in that little space. So it's going to make the pressure increase in that space. Just like the streets, the highway, the freeway never changes its size. It just depends on if you're going after rush hour or before rush hours. So that's the increased amount of pressure, the increased amount of, and you are on pressure running through rush hour, okay? Distended neck veins. Remember I told you the jugular vein distension. That's going to be those neck veins that stick out when a person is pissed off. If there's a lot of volume on board, those vessels in the neck are going to jump out and look all crazy. Dyspnea. Dyspnea is actually difficulty breathing, okay? And a patient with a lot of volume on board is probably going to have difficulty breathing for several reasons. Like I said, sometimes the ticker or the pumper can't handle all that fluid, so that fluid backs up into the lungs. Now, I'm not sure if we should be past A&P, so you should know that the left side of the heart pumps out into the body. Okay, well, if it doesn't get to pump out to the body, it backs up into the lungs, and that's not the way it's supposed to work, so it's going to make the patient have a hard time breathing. And if you have a lot of volume on board, just like I told you, your 1 kilogram is your 2.2 pounds, and your 1 liter, all of that stuff is all the same, you're going to have weight gain, okay? So this is how that patient is going to look when they come to you. Try not to get too deep into disease processes. Like I said, that's the part I really truly enjoy. The labs. This patient who has a lot of volume on board is going to have a decrease in specific gravity, meaning that the urine is going to be diluted, so it's going to be less than 1.010. It's going to be a decrease in hemoglobin and hematocrit. That is going to be the H&H. And I was trying to pronounce it because all of us, we all do have a medical background. We know what hemoglobin and hematocrit is. And then, I'm sorry, I teach all across the spectrum. And then we have a decrease, and this decrease is going to be secondary to hemodilution. So there is so much water in relation to the amount of hemoglobin and hematocrit that it is decreasing the amount. So some of this stuff, guys, is pretty much self-explanatory. I think where we get confused with fluid and electrolytes, besides the fact that we hate it, is that we have to talk about those electrolytes and remember what they do and kind of how they represent themselves. And then we have to think about those compartments and how they shift from compartment to compartment. But I think once you get that down, some of this stuff we know. We know about a patient that's volume overloaded, and we know about a patient that don't have enough volume on. How do we manage these patients? Restore the fluid balance. Try to get some of that fluid off. So we're going to restrict. Okay, so they're going to be on a fluid restriction. We're going to do something that is going to promote excretion, and we love giving diuretics. In the hospital, we'll say keep them wet because we can always dry them out. We'd rather you be wet than dry, so we'll give you some diuretics. And then we're going to monitor respiratory and cardiac status. And the reason why is because they're very sensitive to the volume. If there is a lot of volume on board, like I said, the patient will have difficulty breathing because the fluid backs up into the lungs. And anytime the fluid backs up into the lung, remember we was talking earlier about diffusion and gas exchange. If there is fluid where it's supposed to be having gas exchange, the gas exchange doesn't happen. So we're going to have a decrease in perfusion and ventilations, decreasing with O2 saturations. When there is a lot of fluid on board, the heart, sometimes it can't handle it. And I want you to think about our little frail little lady. Her ticker's been around for 80 years and it just doesn't want to handle that. Whereas us more younger people, we can't handle big fluid changes. Whenever you are thinking about issues with dehydration or volume overload, daily weights and eyes and nose is very important. So you always want to make sure you get a daily weight because you want to make sure that your nursing interventions are actually meaning something. And then serum potassium, we're always going to try to monitor our sodium and potassium, but definitely sodium because it makes our heart beat. Okay. And I'm not sure if you guys are having fun yet, but we are definitely going to have a little bit of fun here. So I always like to throw a little quick review in there just so I can take a little sip of my juice here. Somebody might ask you that one day. Daily weights are the most reliable indicator of fluid loss or fluid gain. 1 liter of fluid equals 2.2, and I didn't put that there, but 2.2 pounds or 1 kilogram. Sodium is the major electrolyte that affects fluid balance. Where sodium goes, water flows. Questions, comments, concerns? No questions, no comments, and any concerns. Okay, cool. Now we're going to get to the fun part. Yay! Electrolytes. Okay, so we talked about electrolytes, and what I will do really quick, because I know you guys are overexcited, I will give you a really brief one for sodium. What is the normal range of sodium? Remember, sodium was represented by Na, and the normal range of sodium is
1.35 to 1.45, 135 to 145.
You're absolutely right. Sodium's normal range is 135 to 145. Okay, so we're going to talk a little bit about sodium. So, hyponatremia. Hyponatremia is a low serum sodium level of less than 135 milliequivalents, okay? So, this means we have low sodium in the blood. No big deal. We kind of know the drill with that. It can actually be from a deficiency of sodium or increase in water. Remember, anytime there's an increase in water, it dilutes whatever electrolyte or what's in there. What you need to know is how that patient comes to the hospital. How's that patient going to present? There is nowhere on boards that they're going to ask you what's the normal range of sodium. Not going to ask you that. Nice to know information. I'm not going to lie. It leads you to look through one less resource. I want you to know, how does this patient look? The doctor tells you you have a patient. They've been on 150 of normal saline for 3 days because they're post-op X, Y, and Z. They start complaining of a headache. That you can barely wake them up. They're very lethargic. They're hypotensive. You need to know how this patient is going to present and how they're going to look, or what you should be looking for. So you want to know if this patient has orthostatic hypotension. Orthostatic is going to be a decrease in blood pressure when the patient changes position, so from sitting to standing from lying to sitting and from sitting to standing. And so you want to take the blood pressure in those ways, from lying to sitting and then standing, and look for the significant drop. Okay, so how are we going to treat this? The usual treatment, like I said, is going to be restriction of fluids, diuretics. We love diuretics. I put Lasix on there because it's our favorite. We definitely like to do that. Sodium replacement. And so you asked me, why are we giving Lasix? Lasix is going to get rid of you are going to lose some sodium. I'm not going to lie to you, but you're going to get rid of more water than sodium, and we're hoping that to get rid of the water, it keeps the sodium. Remember, we don't have a decrease in sodium. We have a decrease in sodium in relation to the amount of water on board. Does that make sense?
Yes.
So if we get rid of some of the water by giving a water pill, a diuretic, which Lasix is the one I put up there for you, then we're going to leave more sodium on board, even though you are going to lose some sodium. I don't want anybody saying, I looked at my nursing drug card and it says that Lasix loses. So it does. It loses more, but it loses more water than sodium. And so, and that way we're hoping to leave some sodium on board. And then you want to make sure that you keep in contact with mental status. As you move forward in your program, when you hear any kind of sodium imbalance, I want you to think of what?
Level of conscious, mental status.
Right. I want you to think neural stuff. Level of conscious, mental status, headaches, seizures, and stuff like that. That is what I want you to think of. Okay? And don't get caught up in your own little world that, in the words that you use in your facility, because we like to just goof it. I don't know, every 3 years they change NCLEX and we change wording. So one year we might decide to say the patient has mental status changes. The next year we might say altered mental status. The next year we might say confusion. So just kind of make yourself broad in knowing that it's going to be a neurologic issue. Something is going to be going on with the brain, okay? And the patient is at risk for seizures. And the main thing that boards want to make sure is that we're sending nurses out there that can keep our patients safe. So you might want to do like seizure precautions. Hypernatremia. So we're going to have a serum sodium level that is greater than 145. So, this is some big guns. This is big stuff. Your patient could, if we don't find this and we don't correct this, your patient could end up dead. So here's the thing. You go into work tomorrow morning, you want to make sure that you're checking your fluid, your electrolytes, and making sure your labs are looking good so that you can catch stuff like this when it happens. If your patient has a sodium level of 150 and they're alert and oriented and they're giving a lecture on fluid and electrolytes, that's not when a problem occurs. It's when the patient is not so alert, or they're older and they're already confused and they can't necessarily talk to you. Usually people that are alert and oriented and all that, and when you have an increased sodium level, your body immediately tells you to do what? You eat a big bag of chips that's salty, your body says do what?
Drink water.
Drink. And that's just kind of what it is. So I want you to think about that. So you're a dehydrated patient and you've been on the beach all day. Your body is removing all of this water. You are hypernatremic. You're going to want to drink. You eat a big bag of chips, you're going to want to drink. So a patient that is alert and oriented with an increased sodium level, their normal body's defense is going to say, drink some water, please. You should be concerned if your patient has an impaired level of consciousness or the inability to pick up a glass and drink. Okay. This hypernatremia also may be from a deficiency in the release of the antidiuretic hormone. And obviously, I like talking about this antidiuretic hormone. Remember, it is, we called it ADH, and I told you the synthetic form was called vasopressin. And I don't know if I told you this earlier or not. It is released from the pituitary gland, And remember, your pituitary gland is your master gland. Okay, so we definitely want to think about that. And your patient who are taking glucocorticoids, they are also going to be at risk for hypernatremia. Okay. How are we going to treat this? So here's the list of how we're going to treat it. IV solutions, make them drink, low sodium diet, obviously. And then don't get so bent out of shape. Remember, guys, when you're studying for this test, you should be thinking about nutrition and what has high sodium. And remember we was talking about where water goes, sodium, where sodium goes, water flows. So think about that as far as blood pressure and picking out a diet for a patient who is hypernatremic. Nursing care is going to be have your patient drink some water, monitor definitely level of consciousness, your IV fluid, and teach your patient to look at daily weights and I's and O's, and teach about signs and symptoms of fluid depletion. Okay. One of the things that I want you to remember when you are correcting a sodium imbalance, and this is something I'm going to slow down so I can make sure that you hear. When you are correcting a sodium imbalance, you want to make sure that you do not cause these shifts to happen too quick. So if you want to prevent a rapid shift of water back into the cells, because that can cause cerebral swelling or cerebral edema. And I mean, cerebral edema, it just doesn't sound fun. It doesn't sound good. So anyway, that's going to be swelling in the brain. We know the brain doesn't have extra room because of the cranium thing there. We call that increased intracranial pressure. And we'll learn about that a little bit more. But that's always a bad thing. So make sure that we are correcting sodium imbalances very slow. And so think about that. I was actually at work at my PRN job a couple of days ago, and one of the nurses asked me, how do we correct a I think her patient had a sodium of 149 or whatever, and she wanted to know why Dr. whatever his name is wanted this patient on normal saline. When you have a patient who is hypernatremic for some strange reason, we give this patient half normal saline, and sometimes we give them D5 half normal saline. So don't be surprised. That is what we're going to do, and probably give them a smidget of Lasix. That is the treatment for hypernatremia. So potassium. Potassium is some really cool stuff, guys. It makes your heart beat. It makes all of the muscles do all of the cool things that they do. So if a patient is said to be hypokalemic, the serum potassium level is going to be less than 3.5 milliequivalents. So I have to be honest, I like potassium. Potassium is my thing because, like I said, I'm a cardiac nurse, so I play around with potassium a lot. The thing about potassium is it has a very low level there. So it's only 3.5 to 5.1, and either end of it is bad stuff. So they may have low sodium levels for a whole bunch of different things. It could be from GI loss, laxative abuse, diarrhea, vomiting, ileostomy, drainage. All of that stuff can cause hypokalemia. It also could basically be associated with diabetic ketoacidosis. So it's a lot of different reasons why that the patient could have that. It could come from overdose of insulin. So we have to kind of think about that. I want you to know that a decrease in potassium can cause your patient to have fatal dysrhythmias, heart dysrhythmias. So we really need to make sure that we pay attention to that. And that is going to be your very flat T waves. And I'm not sure if we're ready for waves or whatever, but when we get to cardiac, I'll be more than excited to talk about those. And so we definitely have to think about that. I want you to keep in memory that it is going to always be a muscular issue when they have a decrease in potassium. So muscle cramps. I actually think I did put that on your screen. And your patient is not going to say, you know what, I have muscle cramps and I'm thinking that I have a low potassium. No, they're going to tell you, I have a bitching Charlie horse is driving me crazy, and you kind of got to pick up, or I can barely stand. Normally I stand perfectly fine. I don't know what's going on. Maybe they'll get confused. Maybe they'll be peeing a lot. You need to be able to pay attention to that. That's why I think it's important to commit the normal ranges to memory. Remember, your patient, 80% of potassium is removed through the kidneys. So keep that in mind as well. Okay, so that's your hypokalemia. Okay, now hyperkalemia is going to be a serum potassium level that is greater than 5.1. And once again, lots of things that oh no, we're gonna still talk about deficit. My bad. I just, I like pictures. That's kind of cute. You like this guy?
He's alright.
He cool. Same thing. Alkalosis, slow respirations, irritability, confusion, drowsiness, weakness, muscle weakness, arrhythmias, irregular heart rate. Those are the things that's very important. His stomach and his heart is asleep. I think that's kind of cute. Wake me up when it's all over with. Okay, I hope that Ira did get you guys these lectures so that you can see these cute pictures. They're really cute. Okay. How are we going to treat it? We're going to treat it by giving the patient IV or oral potassium. We're going to monitor the patient for decreased bowel sounds. Remember, I just told you on the screen before that the belly was asleep and the heart was asleep. We're going to check for irregular pulse because we're going to be looking for those arrhythmias that we were just talking about. Decreased reflexes, decreased muscle tone. Okay, and we're going to also make sure that we're checking urine output. Once again, 30 milliliters an hour. When we replace potassium, I definitely need to make sure that I say this. When we replace potassium, potassium needs to be replaced in a fluid that is diluted. We need to make sure that our patient, if we're giving it IV, it is never IV push. Because that's lethal injection. It will cause the heart to stop immediately. We should not give more than 20 milliequivalents an hour. It has to be diluted. It has to be on an IV pump. If we give more, we definitely should be given through a central line because potassium is very irritating to the vein. We would prefer this patient to be on telemetry for obvious reason. That's a heart monitor so that we can monitor for those cardiac dysrhythmias. And let's see. And we can also tell our patient or encourage our patient to have foods that are high in potassium. And believe me, on boards, we will not have bananas. For some strange reason, we're over bananas. So I want you to think about your citrus fruits, raisins, organ meats, avocados, spinach, dry fruit, and broccoli. Avocados, broccoli, spinach, raisins. That's the kind of goofiness they like to have. No bananas. They won't ask that. If you see bananas, don't get all thrown off. Okay. So, hyperkalemia. Hyperkalemia is going to be a serum sodium level that is greater than 5.1. So we have this cute little guy here. Do we have a cute little guy? Is he on your screen?
Roger.
Okay, cool. Muscle cramps. Paresthesia is numbness and tingling. That feeling you get when you sit on your leg because you think you're still 16 or something. So that's what that is. Numbness and tingling. Irritability, a decrease in blood pressure. EKG changes is going to be, is going to be, I've been having, Ira, why won't this work for me anymore?
What are you trying to get?
Remember earlier today I could make it,
zoom in.
Yeah.
Right there. Right click. 1, 2, 3, 4 down.
Oh, 4. Okay. So remember I was telling you, so we have your P wave here, and then you have your QRS here, and then there's your T wave there. And remember I said it would be flat if it was a decrease in potassium, and then if it was tall or peaked or spiked, it's an increase in potassium. So that's pretty much what I was talking about. I wanted to give you a better look of what was going on. I want you to know this because this is very important. This is the most dangerous electrolyte imbalance, okay? It is. Like I told you earlier today, we do not give potassium IV push because that is what they use for lethal injection. So we really want to make sure that that we realize that this is the most lethal injection. Now here, I mean lethal electrolyte imbalance. Now here's the thing. Somebody in the world is going to say, well, my dialysis patient run around with these crazy potassium levels. Remember, when your body starts to slowly compensate for the fact that it has the levels, it's a little bit different than a person who is a big burn victim and there were big potassium shifts that happen really quick. Okay, some of the things that will cause this could be big burns, crush injuries, renal failure, potassium sparing diuretics, um, and blood transfusions actually too. Here's our sheet here. Pretty much the same thing we said. Decrease in renal function, metabolic acidosis, and we'll talk about that. I'll do my acid-base balance one and try to get that one out as soon as possible. And then signs and symptoms, explosive diarrhea. That sounds really fun. Vomiting, muscle cramps, paresthesia, and a decrease in urine output. Remember, this patient is going to come in talking about leg cramps. I just feel weak. I can barely stand. They might be in ventricular fibrillation or cardiac standstill. Remember, there are certain drugs, potassium-sparing diuretics like aldactone. ACE inhibitors also increase potassium levels. Lisinopril may also contribute to it as well. Okay. Now, of course, now we have this patient who has this increased potassium level. We need to treat it. We need to figure out or anticipate what the doctor is going to do. And what is the doctor going to do? He's going to correct the underlying cause. Hopefully, if it's a renal issue, we'll go dialyze the patient. We are definitely going to restrict potassium intake. We like polystyrene sulfonate. It is a Excelsior. We like to give that. The only thing about Excelsior, and it's a wonderful thing, is that it takes a little bit of time for the gut to exchange those ions and for you to stool it out. My head works really, really well, so I'm going to go ahead and tell you this. You can also give some insulin. Insulin will make the potassium go from intravascular to intracellular. We like to give calcium gluconate. The reason why we give calcium gluconate, and once again, that's some stuff that you probably don't need to know, is because in the process of having all of this increased potassium in your system, the calcium gluconate will protect the heart. It says, little heart, don't worry. Everything's going to be okay. Okay. And in nursing care, obviously I's and O's, make sure that we're monitoring for the potassium that we're giving the patient, or what meds we're giving that may cause it. Make sure we are checking laboratory values and all of that good stuff. So those are the things we're going to worry about. I talked about the insulin. I talked about, obviously, if you give insulin, you have to give glucose. As far as that's concerned, my favorite electrolyte is coming up. Psych. Chloride. I don't even know if I have anything to tell you about chloride. It's usually piggybacking off of the other electrolytes. We really don't talk about it really much. The hyperkalemia is associated with metabolic acidosis. Hypo is usually from some sodium loss, because they are hand-in-hand friends. And with that, my friends, we have covered chloride. Okay, I'm usually in clinicals with students and they'll say, Miss Davis, what about chloride? And I'm like, nobody cares about chloride. Okay, so we definitely care about calcium. because as soon as we have a decrease in calcium levels, it puts our little people at risk for bone fractures. So a little elderly lady's going to fall on the floor and break her arm because she's hypocalcemia. Okay, so remember, the calcium is going to be regulated by the parathyroid hormone. There is about 30% of calcium comes from food that is absorbed in the GI tract. So keep that in mind. I do have on your screen here that decrease in calcium levels can come from various things, diarrhea, a decrease in calcium or vitamin D, multiple blood transfusions. Now you're like, dang, blood transfusions doing all that stuff. They're usually multiple rapid blood transfusions, so you don't have to worry about that. It is important to kind of get an understanding of calcium because it does help with the transmission of nerve impulses, myocardial contraction, blood clotting, teeth and bones, that kind of goofiness. One of the things I do want you to know is that your patient who is calcemic is at risk for bone fractures. I think I've said that twice, so I don't know. I may think it's important and some kind of thing. We definitely want our patient to drink somewhere between 300 to 400 milliliters of calcium a day if they are hypocalcemic. Okay, yeah, calcium. And as you can see, I have to be honest with you, the more and more important an electrolyte is, the more and more I want to say about it. I don't want to put a lot of stuff out there in the atmosphere that just really isn't all that important. Like I said, I do think that you should know that it is affected, the parathyroid controls it and all of that, and that a patient that doesn't have enough on board is at risk for fractures, and a patient that has too much is at risk for renal calculi. So keep that in mind, but not a whole bunch to say about calcium as much. When we do decide to test calcium, we test it basically talking about these three things. Oh, well, these two things here for real. And this is number A is going to be it starts with a C, but it's actually just Volschek. And basically it's affected when you touch cranial nerve 7 on the face, and the patient will have like a twitching to the face. And it's CHVOSTEK, Volschek. The CH is actually silent on it. So if you touch that facial nerve, right in front of the ear, the patient will have that twitching that you see there. And then B is actually a spasm, a carpal spasm, and you will see it done. It'll catch you off guard, but you'll actually see it done when you inflate the blood pressure cuff. And so that's basically how what those two are, and both are responses to a decrease in potassium levels as well. Magnesium. Remember magnesium. Last one on there. So we have a hypomagnesium is less than 1.5, a decrease in GI absorption. Usually whatever you're eating, whatever doesn't have enough. Everything comes from vomiting and diarrhea. And then your hypermagnesium is a greater than 2.5. And it's usually going to be from your patient who is in renal failure. We gave them too much magnesium, or the patient is preeclampsia from pregnancy. And so think about those kind of things. Some of the causes of the patient that's going to be hypo is going to be chronic alcoholism, and it's probably going to be that more than anything. Some of the medications that could cause hypomagnesium is going to be your amino glycosides there, insulin, Lasix. Patient's probably going to present with a decrease in level of consciousness, hyperactive deep tendon reflexes, And so when they are hypo from this, we're going to increase the foods that have magnesium in it. We may give them an IV or deep IM injection, but to make sure that we check renal function before we do any of that stuff. And the patients that are going to be hyper could be caused from renal dysfunction, advanced age, Addison's disease, or adrenal cortical insufficiency. This patient is going to possibly come in bradycardic, meaning a decrease in heart rate less than 60, and possibly a heart block. And how we're going to treat this, if we don't really get all bent out of shape about magnesium, we will replace it. But if the patient is very hyper, we could definitely give them calcium gluconate in the emergency situation. And then, like always, you always want to end your presentation with a cute little picture. One of the things I will tell you is calcium and phosphorus have a inverse relationship. When one is up, the other is down. When one is down, the other is up. So that's our little cute people. They never, they're not in equilibrium. And so, you know, you said that basically to say I have nothing to say about phosphorus. So a quick review. When we think about K, needs to be on a K, remember, is your potassium needs to be on a pump never more than 20, and the patient needs to be on a heart monitor, which I call telemetry. Remember, safety with patients and muscle weaknesses and gait belts. So your patient comes in with a 2.2 potassium. You might not want to be trying to walk them to the bathroom. And don't forget, chronic hypocalcemic patients are at risk for fractures. And I've said that 3 times. So I don't know. Maybe I thought that was important. So I know you guys are like, what the hell? She talks real fast. I would tell her for the next one, slow down a little bit. We had about 2 hours where I talked about the subject that everybody hates to love or loves to hate. And so I do want to do like a really quick summary just so that we have a good understanding of what we talked about. Some of the things we talked about is that the body actually needs to be in homeostasis. It has to be in a continuum of equilibrium, that quick, steady thing there. And water. Water is very important. It removes nutrients around. It transports electrolytes. It's about 60% of the body. You can't live without it. We wanted you to know that infants have a larger body surface area, so they have a greater risk for having fluid volume deficit. There is muscle has more water, and so fat has less, and our obese patients are going to be more at risk for volume issues. Fluid compartments. There are 2 major compartments. You have your intracellular, everything going on inside the cell, and your extracellular, everything outside of the cell. Remember I said I want you to think about cells as far as cellular tissue, cellular levels, and your extravascular outside is going to be intravascular, interstitial, transcellular. And for you guys that just get confused about transcellular, remember that's the cerebral spinal space, the peritoneal space, the pleural space, synovial fluids. Electrolytes. Electrolytes are those things that we keep talking about. When they are put in water, they break out into ions. Ions have a charge. It's either a positive charge or a negative charge. Positive means it's a cation. Negative means it's an anion. Okay, electrolytes. When you go get through listening to this, you might want to think, hey, sodium is my friend, 135 to 145. Potassium, I like that one as well. It is 3.5 to 5.1. Sodium lives outside of the cell. Potassium lives inside of the cell. And patients who have issues with calcium are going to be the patients who are at risk for fractures or bone breaks, okay? How's this fluid going to move from compartment to compartment? We talked about diffusion from high concentration to low concentration. Osmosis only has to do with water. Active transport needs energy. The energy is going to be adenosine triphosphate, and that's what helps move everything. We talked about a semi-permeable membrane, meaning I let some stuff in, I don't let some stuff in. So I want you to know about that. We talked about osmolality and osmolarity. Don't get all caught up in the words, how thick the solution is, how thick the blood is, how concentrated the urine is. And we talked about that. We said that the osmolarity is greater than 300. It is said to be hypertonic. If it is less than 270, it is said to be hypotonic. We talked about when we put a cell in a hypotonic solution, it blows up and swell. In an isotonic solution, it does nothing. It is the same volume as plasma or the same concentration as plasma. We talked about if we put a cell in hypertonic solution that it will shrink, okay? Our isotonic, meaning that it is the same as serum, is going to be normal saline, which is 0.9 normal saline, or lactated ringers. We also talked about D5W, which is isotonic in the bag and hypotonic in the body. We talked about hypotonic solutions is anything that is less than 1. So that's going to be your 0.45 normal saline or your half normal saline, your 0.25 normal saline or your quarter normal saline, and your hypertonic stuff is going to have sugar in it or be greater than 1. When I say greater than 1, that's 3%, which is greater than 0.45 normal saline. I talked about the body staying in homeostasis. I said the kidneys is important because it handles the volume and makes you pee or not pee. Antidiuretic hormone is the hormone that tells the kidneys to pee or to not pee. The angiotensin aldosterone, the renin-angiotensin aldosterone system, responds to a low blood volume, decrease in tissue perfusion, and it tells your vessels to get smaller and hold on to more fluid. The atrial nephropeptide is the volume, the heart's response to volume, and then we definitely want to talk about the thirst mechanism. We also talked about older people. Older people, they lose their elasticity in their skin. Little baby people do not have blood pressure changes. We talked about the patient that was dehydrated. They don't have enough fluid on board. They have the increased heart rate. They have the decrease in fluids. We have people that have too much fluid on board. They're having they could have heart issues. They can have difficulty breathing from all the fluid that is on board. And then we talked about the electrolytes, and you're like, please don't go over those anymore. Remember, when I said I want you to think about sodium, I want you to think about neural issues. I want you to think about headaches. I want you to think about level of consciousness. When you think about potassium, I want you to think about muscle cramps, the heart, and how that operates. When you think about calcium, I want you to think about menopausal women and being at risk for fractures. And I want you to keep remembering that if we have to replace potassium, the potassium cannot be IV push. It has to be on a pump. And when I say pump, I mean an infusion pump, an IV pump. It has to be diluted, and it has to be the patient should be monitored on a cardiac monitor. If a patient has too much potassium, the patient will have tall teeth. If it is too less potassium, the patient will have flat teeth. Okay. Let's see. What else? Chloride, I didn't say much about. Magnesium, I did not. Oh. Magnesium, I didn't say much about. Don't forget about your Volts check and your True Cells, which is True Cell. I didn't even mention it. The True Cell one was the carpal one. It's your, I better say politically correct. It's the funny signal when the blood pressure cuff is placed on the arm and inflated. And we talked a little bit about magnesium. I told you that we will replace magnesium IV or IM. One of the things I wanted to say about your hypermagnesium is they'll have a decrease in respiration. They will definitely give you some nausea and vomiting. They could come in with bradycardia, a heart block, a decrease in deep tendon reflexes, confusion or drowsiness. And if it is extremely high in an emergency, we give calcium gluconate. I also mentioned that the calcium and phosphorus have an inverse relation. When one is up, the other is down. Guys, I would love to put up a lot of lectures for you guys. What I would like for you to do, if you can, is I guess you have your own Facebook page. Let Ira know your comments and concerns, and be honest with them so that I'll know exactly what I need to change or what you want me to focus on. I can tell you one of the things that I want to focus on is I probably need to slow down for the next time. But I was really trying to get meat and potatoes. Fluid and electrolytes can be really tricky. I'm right here under 2 hours. I think it's really good. I would love to continue to do this for you guys because this is really good. I actually was sitting here having me a beverage while I'm doing it. It wasn't so bad as I thought it would be. So please let me know comments, concerns, suggestions, or anything you want me to do differently, anything you want me to focus on. I will definitely put up the ABG lecture. It's already made. I have lots of them actually made. It's just the sitting still to do them. And I will see you guys next time. I really appreciate you guys taking the time out to listen to the lecture. And if you have any questions about this lecture, you can actually email me at SHEMELLE@yahoo.com. It is actually my the first letter of my last name and my first name, SHEMELLE@yahoo.com. Get in touch with Ira. He tells me he sits next to me every day. Okay, have a nice day, guys. Bye-bye.